Good afternoon. My name is Jeffrey Campbell. I am the HIV program manager with the Houston Health Department. And as a part of UCHAPS, I am the government co-chair for our UCHAPS steering committee. So welcome to every one of you who are joining us today. We had a really good conversation yesterday around drug user health. And thank you for joining us for a continuation of drug user health. It will be a roundtable today with UCHAPS. So we're very excited to have you signed on for our conversation again today. Welcome for those of you who today is your first time meeting with us for this two-day conversation. Very special welcome to you, and thank you for taking the time out to be with us on today. Before we begin our roundtable discussion, Carl Bologna, the Director of Government Affairs at AIDS United, will provide a policy update on the potential impact of consolidation programs and the changing landscape of healthcare in the Trump administration to inform our discussion today. Carl, your line is now open and you may begin.
So thank you for that introduction. I actually am going to go ahead and introduce AIDS United's Syringe Access Policy Organizer, Nora Maria Fuller, who's been really closely tracking and working solo and in coalition on the emerging opioid response to give you all the latest updates, and then I'll follow up with what's going on in Congress. Nora?
Hi, everybody. I think that all of us were very confused when Trump said it's an emergency, I'm declaring it an emergency. Instead of FEMA declaring a national state of emergency, what happened was the Secretary of Health and Human Services declared a public health emergency. Before we jump into the difference between those two things, I wanted to note that there is a growing trend among states to issue statewide emergency declarations. So we've seen this in Alaska, Arizona, Florida, Maryland, Massachusetts, Pennsylvania, South Carolina, and Virginia. Also, all the jurisdictions that are receiving opioid state targeted response grants, part of the requirement of those grant awards is to create an opioid response plan. So generally you can find that statewide. Sometimes it's different counties or certain jurisdictions that are making those plans. So back to the administration, public health emergency only lasts 90 days. So we've seen that it has been renewed by either the acting or the Secretary of Health and Human Services since that first October one was announced. It taps from the Public Health Emergency Fund, which Congress hasn't really given any money to. When the declaration was made, it had $57,000 in it, and it's unclear that any of that has actually been used. So the way that a public health emergency designation can work is it can waive certain patient regulations, so about their safety and privacy. It can modify requirements for Medicaid, Medicare, and the Children's Health Insurance Program, and it can create temporary healthcare positions. We haven't really actually heard of much of this happening, although there was some coverage of the idea that people in rural areas might have better access to telemedicine. I haven't seen that reported happening. If the administration had chosen to go with a national state of emergency, it's also finite, but it expires after a year. It is FEMA that would make this declaration, and it's declared through the Stafford Disaster Relief and Emergency Assistance Act. It's been a lot of different things. It's roughly defined as a situation beyond the ordinary that threatens the safety and lives of American citizens that cannot be resolved with current laws and existing resources. So a national state of emergency would be able to bring funding and resources logistically from a number of federal departments. I think one of the concerns with a national state of emergency is that you could see law enforcement mobilized with that kind of an emergency. Also, it's generally been place-based. So when we see that with hurricanes, for example, where a certain region is getting this national state of emergency, given that the opioid crisis is happening nationwide, that might be a little bit of a difficult thing for FEMA to be administering. So what has the administration actually done? You can find a great document that they put out about all the things, all the money that they've administered. But generally that's stuff that Congress had okayed during the Obama administration. So some things that the administration did. They named Jim Carroll to be the director of the Office of National Drug Control Policy. He has no experience. They hosted a pop-up memorial at the White House that was called Prescribed to Death, and it was really whitewashed. It was a series of faces of people who had died from opioid overdoses, and they were etched into these like white pills that were mounted on the wall. They created a terrible series of short videos in which people choose to self-harm in order to access pharmaceutical opioids. It's a really, really bad group of videos. There was some rumor about the president giving like $100,000 of his own money to it, but then that wasn't exactly tracked as having happened. Of course, we know that Kellyanne Conway is like the face of the administration's response to the opioid crisis. The Surgeon General, Jerome Adams, has, he was in Indiana and part of the lifting, creating syringe access there in response to the Scott County outbreak. So he's now our Surgeon General, and he's spoken pretty positively of harm reduction at conferences around the country. He made a comment that was like pro safer injection sites at a conference of emergency medicine, but the administration made him pull that back. So they like went out to all of the news outlets that had quoted this and had them edit that statement. I think that what we've seen a lot of is coming out of the Department of Justice. So last Friday, Jeff Sessions announced a new $6 billion program called Operation Synthetic Opioid Surge, SOS. So it's a surge in 10 districts with some of the highest overdose rates, and they're going to be prosecuting every provable case involving the distribution of fentanyl or fentanyl analogs and other synthetic opioids. So regardless of drug quantity, they will be prosecuting every one of those cases in those 10 districts. They also announced that as part of this healthcare fraud enforcement action last month, they were charging 76 doctors in 84 opioid-related cases. So yeah, there's a whole list that the Department of Justice and the Department of Health and Human Services put out together in a joint announcement. And we're seeing that the feds are raiding offices of doctors who are also prescribing addiction medicine. Even the former president of the addiction medicine group, his clinic in Rhode Island was raided recently. Do you want to talk about Congress?
In terms of, you finish up the opioid piece, and then I'll just,
okay.
Yeah.
So basically what we're seeing is the administration, as well as Congress, is really trying to leave the opioid crisis response open to states and localities. Congress did, have a lot of hype over their opioid crisis response bills. The House passed their package of bills. It's all collected into H.R. 6. We expected the Senate to mark theirs up this summer, and I'm not sure if the timeline has changed because of the Supreme Court justice hearings. Nothing in the bills would really shift the kind of systemic failures that have led to the opioid crisis. Not a lot of them are giving a lot of funding. You're seeing more restrictions and crackdown on physicians, pharmacists, opioid prescriptions, increased funding for drug interdiction and anti-drug education. But I do want to call out two parts that we are paying attention to. So Legal Action Network, the group that led the charge against the Rockefeller laws, they're spearheading the effort against HR 6082. It's the Overdose Prevention and Patient Safety Act. It removes drug treatment patients' ability to control the disclosure of information to health plans, healthcare providers, and other entities. And then we're interested in supporting the Eliminating Opioid-Related Infectious Disease Act. So in the House, this is 5353. On the Senate side, it's 2579. These bills have been rolled into the larger opioid crisis response packages, and they authorize $40 million a year to track opioid use-related infectious diseases, specific to HIV, hepatitis, and endocarditis. It's passed the House as part of HR 6, and it's on the Senate side as part of S2680, the Opioid Crisis Response Act. In terms of appropriations, so there was this Eliminating Infectious Disease initiative as part of the president's proposed budget. And we are seeing that be created in the Labor, Health, and Human Services appropriations bill. The good thing about HR 5353 and S2579, the Eliminating Opioid-Related Infectious Disease Act, is that it would be a vehicle for that kind of elimination initiative to receive funding for longer term. Whereas this elimination initiative that is proposed in the Labor, Health, and Human Services bills could pretty easily be cut. In the House's version, it's funded at $20 million, but that came at the expense of other public health funds. In the House's language, it says it's for a demonstration project that could be limited to only 5 sites. But the Senate's version is only funded at $5 million, and it has more flexible report language, so it's not a demonstration project. Our strategy as part of the Hepatitis Appropriations Partnership is to push for the Senate's version of the language and hopefully get a little bit more money than that $5 million. Again, if the standalone bills that are part of the opioid crisis response get passed, then that's a vehicle for those additional funds without the cuts to the other programs.
Nora, can you remind us of the community ask for that?
Yeah, so the community ask is actually not for this elimination initiative. The elimination initiative, it would go for all of these, for HIV and hepatitis and everything. But our ask is more direct. We want the Department of Viral Hepatitis to receive a total amount of $134 million. So it was at $34 million in 2017. It got a $5 million bump to $39 million. So we've been asking for the 2019 budget to have an additional $95 million. And we haven't seen that. It's been flat funded with the caveat that they're trying to create this other elimination initiative. Any questions?
If you have questions for Nora or for Carl, please feel free to raise your hand or to type your questions into the chat box, and we'll put them into the queue.
And Nora's going to field questions on the part that she just delivered, and then she's going to take off for another meeting, and I'll provide a brief congressional update.
Great. Thanks for that plan. All right. Any questions for Nora before she zips off to her other meeting? I do want to acknowledge Jalicia. She says, thanks, Nora, for clarifying the difference between a public health emergency and a state health emergency or a state of emergency. So thanks for that acknowledgement, Jalicia. Another question.
So I see this other question. It's about naloxone. Are we getting it to community-based programs versus law enforcement? generally, the state targeted opioid response grants did have some naloxone that went out through SAMHSA. So that would be, it's very different every state. Usually it's a single state agency. It might be called, Department of Behavioral Health or Department of Mental Health, or like Department of Human Services. So that naloxone went out into the community, but because those SAMHSA, the SAMHSA funded departments haven't been working very closely with public health, there was a lot of that naloxone has gotten lost in lost to communities. So it's really different place to place. And then generally, yeah, we're seeing way more naloxone go to law enforcement.
Are there any other questions for Nora? Okay.
All right, if there aren't any more questions, I just want to let you all know that I am keeping the Coalition for Syringe Access website updated. So there's like a news scroll, and I collect local news that's mostly related to syringe access from all kinds of local areas. So if you're interested in knowing what's going on at a more granular local or state level, then you can always take a look at that. And I am available if you want to discuss any of the themes that are coming up in the news. So I want to just bring y'all's attention to, there's a couple of locations in Indiana and West Virginia where syringe access programs are requiring retractable needles. We do have resources about why retractable needles are too dangerous to be providing at syringe service programs. So you can always reach out to me for that. There's reports that because people are unhappy with public injection or injection in bathrooms, that some chain restaurants are installing blue lights in the bathrooms. The blue lights are supposed to make stains harder to find. So again, more dangerous. And if you need any resources on these other themes, these like more political themes about needle litter and stuff like that, we're paying attention and we're working on that. I also wanted to put a call out for help. So the Humboldt area for harm reduction in Eureka, California has actually been facing pretty violent community opposition. So if you know anybody, if your loved ones are in Eureka, California, if you can ask them to support Hatcher's, what they call it, Humboldt Area Center for Harm Reduction. Today at 6 p.m., they will be going to the Eureka City Council, and generally there's been some really big demonstrations against them whenever that happens. So if you want to link in with how to support them, also please let me know.
Okay.
Great. Thank you, Nora.
Thank you, Nora. Guys, don't forget that Nora has put her email address here in the chat box, infuller@ageunited.org. So Carl, I'm going to move it on over to you.
Wonderful. Thank you. So just wanted to take a moment to address some of the questions I understood you all wanted to hear about. So I'll provide an update on what's going on in terms of federal funding around healthcare programs and programs that affect people living with HIV. I'll talk about some of the president's efforts to consolidate safety net and general health programs, including the Ryan White program, and just what's going on generally in Congress. So really briefly, as some of you may know, the Senate Appropriations Committee will be marking up 3 bills this week. That'll include the State and Foreign Operations Bill, Homeland Security, and Financial Services and General Government. None of these bills house funding for HIV or health programs. They are, however, scheduled to mark up their Labor, Health, and Human Services bill next week if they are able to stay on schedule, which they have done to this point. As you know, Labor HHS contains the Ryan White program, CDC, and other vital HIV programs that we really care about. So for its part, the House side, appropriators have passed the Labor, Health, and Human Services bill out of committee by a vote of 30 to 22, with HIV-specific funding for the Ryan White program and earmarked funds at CDC remaining at level funding from FY18, in this climate, we are both thankful for level funding and also disappointed by level funding. Level funding, means that there was no cut, but it also means that no formal cut. But after several years of level funding, that becomes an effective cut, not keeping pace with inflation and rising healthcare costs. There were also amendments that were passed a part of that to increase funding for some health agencies, notably CDC and SAMHSA, to address the opioid epidemic. The House bill also included a number of what are known as poison pill policy riders. Included in that language was an effort to prohibit funds for the use of federal funds to support safer consumption spaces, which are critical interventions in curbing the HIV epidemic. This language was thankfully not included in the Senate. But there was also a measure barring funds from the use from being used to carry out the ACA Navigator program, which is a continued effort by conservatives and the administration to undermine the Affordable Care Act. And there was also a rider that would disallow, that would allow adoption agencies to refuse adoption services to LGBTQ people, parents and families because of religious beliefs. These are expected to be negotiated out of the bill and are seen as non-starters for Senate Democrats. The Senate has really tried to preserve a more bipartisan approach, unlike the House. So we're really hopeful to be successful in removing safer consumption language, removing this barring of funding for ACA Navigator programs, and particularly for the adoption services for LGBTQ individuals. Conferencing of the bills were set to begin last week, starting with the Energy and Water Development, Military Construction and Veterans Affairs, and Legislative Branch Appropriations minibus. But that was postponed and no rescheduled date has been announced. With all of that being said, it is still expectation that it is very likely, as we approach an election, that we'll see a continuing resolution to continue funding for the government, the programs that we care about. So stay tuned. We'll continue to update you all. Then up next, thinking through some of the president's attempts to consolidate safety net programs, the Roundtable program, and attempts to call back funding. First, I think you all were watching that the president had submitted a rescission package where he sought to cancel $15 billion in unspent funds from previous years. That effort was blocked in the Senate with a procedural vote to discharge it from the committee. That failed by 48 to 50. It required a majority to advance, so that is dead. Then in terms of reports that the White House was consolidating programs, as you may have seen a couple of weeks ago, they released a plan for reorganizing the federal government that included a significant consolidation of safety net programs and renaming of HHS to the Department of Health and Public Welfare. This obviously harkens back to a time and a set of a way of describing the programs in an unfavorable way. Progressives do not agree with the title of public welfare and is really just politically motivated. The reorganization aims to move safety net programs like SNAP under HHS oversight. The plan would also trim the Public Health Service Commission course to no more than 4,000 officers, down from about 6,500, and many of the proposed changes would require approval from Congress. That's the good news. I know folks have worry about these consolidation plans, attempts to streamline the federal government, really ending in fewer services, fewer federal employees, and not better care. These are unlikely to pass congressional approval. There are some things that he can do without congressional approval, but they are significantly less impactful. And then another big thing I think that folks are following, we're really concerned about, is the Supreme Court. As you all know, the president put forward Kavanaugh as his nominee to the Supreme Court to replace Justice Stevens, and that is he's a conservative ideal candidate. He sits on the 12th Circuit Court in D.C. And has really proven to be not a friend of progressive policies, not a friend of women's reproductive health care. The Democrats do feel as if there is a path to significantly delaying that nomination. I don't want to be quite so optimistic as to say a path to success in stopping his confirmation, but they plan to really focus on getting as much information out there about their concerns with Kavanaugh. There's a lot to look at from his 2003 nomination to the district court. We will be combing that court record. We have been told that the DOJ is ready to bring in as many as 300 attorneys to help move forward and process the millions of documents that are expected to be examined by the Senate for the confirmation. And we will be supporting Senator Feinstein, who is taking lead for Senate Judiciary and helping to suss through that information. We're going to encourage others to do the same, and we'll provide information to UCHAPS for opportunities to weigh in with your senators and with Senator Feinstein as well. Any questions?
Any questions so far for Carl? We're all good? You can either enter your questions into the chat box, or you can raise your hand. No?
Can anyone hear me?
Yes.
Oh, okay. I didn't know how to do it. You said
Hi, Nikay.
Hi. Just a couple of questions. So in regards to the issue that came up with the Ryan White funds, can you confirm were those existing Ryan White funds that they were trying to take, or were these funds unused dollars from previous years? And do you anticipate them trying to do that again? Because I know they're trying to find, ways to basically make up for the tax cut bill that they passed. And so I was just wondering, do we see that coming back up again? And is that new money, or is this just money that was left or didn't get used, old money from the Ryan White programs? And I asked, go ahead.
I'm sorry.
And I asked because I know this is, we're starting to hear that a little bit on the HOPA side. So the old HOPA funds that are unused, the Treasury is starting to say, hey, we're going to take it. So, yeah.
Thank you for that question. So just for clarity, just in case everyone doesn't know what she's referring to, Slate magazine last week reported that Ryan White funds were being transferred to HHS Office of Resettlement, or Office of Refugee Resettlement, to backfill its funding needs as a result of the uptick in separating children from their families and children arriving at the border alone. So it seems to have come to light that these funds were in fact unused, unobligated funds from a few years ago, most likely. So it should have no impact on the operation of the Ryan White program or future scheduled distributions of funds for recipients for 2018. However, I think it's been important. We AG 98 put out a statement. It's important to speak that it's unacceptable to use funds that were intended to help people living with HIV to go ahead and take that and use that for other purposes. We stand by that, but are thankful to see that it's not impacting funds that plan to be spent. These funds were being sent back to the Treasury.
That is really good to hear. I think, and while I'm not conservative, I spend a lot of my time working with individuals who are conservative, being in the South, in Houston, Texas. I think what would be prudent for us to do is to include in our language, because I feel like what they're going to see with that particular argument is we didn't spend our dollars and we're wanting to tell you, no, don't take it away. We have to make sure that every single dollar we're getting from the federal government, whether it's through HUD, through HRSA, through CDC, that we are spending all of it or as much of it as possible. And I think conservatives won't see that type of argument as one that's justified. So I'm glad they didn't do it, but I think we've got to think like them and be able to provide answers that they will be able to get on board with us on.
I agree wholeheartedly. I think that's a major vulnerability for us, and we really have to make sure that we're spending those unspent funds in a timely fashion. And I thank you for bringing up HOPWA. I'm definitely aware that the HOPA program, just because the way disbursements work out in different locales, tend to carry over a lot of funds from past years. So we should be looking out to, one, get those funds out the door, but two, to be able to message why they need to not touch those funds moving forward. So thank you.
Thank you. That was it for me.
Thank you, Nikkei, for those questions. Very, very good questions. We appreciate that. Are there other questions, comments for Carl? Either in the chat room, or you can, the chat box, or you can raise your hand. Carl, so this is Jeffrey, and you may have really covered this in your response to Nikkei's question, but I want to go back to it because I was taking a few notes. In regards to the article that Slate released about the potential that Ryan-White funds were going to be moved to address the immigrant issue, what can we do on the ground here? Because I know when it first came out, there was a bit of an uproar. And of course, that happens when we get pieces of information. And so you've given us today more information than I know I had. So what do you suggest for us moving forward with situations like this? Not just as individual jurisdictions, but as a collective body, as UCHAPS, on how to, even if we can't get ahead of the train, to get information out, if we can catch up with the train so that we are immediately responding to information that may be partially correct, but there's been a lot left for the imagination, for conjecture, for all the things that happen when we read an article?
That's a tough question to answer. It's complex. I think first and foremost, I hope you all see AIDS United as a resource. This was reported the second we got it. We reached out to HRSA and HAB. We certainly reached out to the reporter, to appropriators on the Hill who were required to receive notice of transfer of such funds, and really just started gathering information. I think it was important that we put out a statement very quickly, but put out a nuanced statement that said this was a newly emerging issue, and as giving the administration the opportunity to give us more information, not to just pass judgment immediately. And of course, we then learned that this was funds that were being sent back to Treasury. So it's a nuanced situation, but it's still important that they not use these types of funds for other purposes than helping people living with HIV. But so I think first and foremost, please use us as a resource. UCHAPS is a member of the AIDS United Public Policy Council, and we're here for you all. I think then aside from that, I think you can engage with your members of Congress as well. When an issue like this comes out, you can call and say, hey, what's going on? Can you make an inquiry to the administration? You can do that with your Republican and your Democratic members. And I think they'd be happy to help get you a response, and, sometimes get more information than you could on your own. Okay. Thank you, Carl. We just have a question that popped into the chat box from Paul Harkin in San Francisco. His question says, how do we best utilize the bipartisan energy around the opioid crisis, quote unquote, to de-silo HIV prevention and integrate OD prevention and naloxone distribution and HCV services? I mean, I think that's the question of the moment. What we've been seeing out of conservatives is everyone wants to have a positive impact on the opioid crisis. They want to, save people's lives. They want to, looks like, there's obviously a move to stop criminalizing people that suffer addiction or substance use disorder. But the approaches have been varying from conservatives to progressives. So I think there's a lot of opportunity, but there still needs to be a lot of education. We want to see direct services and not just naloxone for police officers. One of the things that I think I forgot to mention, maybe Nora Maria Fuller did mention it, but in the appropriations bill, no, I talked about the safer consumption language. So that's counterproductive to bar federal funding for safer consumption sites. There are localities all over the country that are researching the notion of safer consumption sites. We know that once people have access to safer consumption sites, then they're basically that's an entry point to care, and then that's a potential entry point to recovery support, and then to testing for STIs and HIV and testing and treatment. And so I think it's still a significant amount of education that needs to take place. But then, when we saw this safer consumption site language enter the bill, we did immediately, not just AIDS United, all of our coalition partners mobilized and reached out to our members of Congress, both Republicans and Democrats alike, told them what the impact that this would have, that it would have a chilling effect on communities that are trying to figure out how to deal with the opioid crisis, rather than passing, legislation that would handcuff localities from addressing the opioid epidemic in creative ways. So really, it's all about education at the local level with your local policymakers and also federal policymakers.
All right, great. Paul, did that get you the answer you were looking for?
Yeah, I think that's something that we can see. There's so much energy around this, and I think everybody has to leverage this to the fullest extent, because this is one of the few times that we've seen bipartisan consent. And like you were saying there, saving lives is a big deal, and the saving lives happens on the continuum. So the more improvements that we have that serve active drug users, we get the HIV, the Hep C, the STI, and then primary care linkages through that. So I think this is a huge opportunity for a lot of jurisdictions to move the needle. So thank you for that.
Sure, thank you.
Thanks, Paul. Anyone else have any other questions for Carl before we move on to our next presenter? Okay, great. Well, Carl, thank you so much. Thank you for the work that you do and that AIDS United does, and we appreciate your continued support with the work that we're doing at UCHAPS as well. So thank you so much and have a great afternoon. And thanks again to Nora for her part in this presentation too.
Absolutely. Thanks for the opportunity. I look forward to speaking with you all soon.
Sure. Great. And for those of you who are still taking a look at the chat box, Carl did leave his email address there, cbaloney, BALONEY at AIDSunited.org. So we've got both Nora and Carl's email addresses there. So we are going to move on to our panel discussion. Jalicia Jolly will moderate the panel discussion. Jalicia is a writer and PhD candidate at the University of Michigan. She is researching the dynamics of race, gender, sexuality, and health in the lives of HIV-positive African-American and Caribbean women. She's written on HIV and AIDS, reproductive justice, and anti-racist feminist organizing in venues such as the Huffington Post, Rewire Black Youth Project, and the National Center of Institutional Diversity at Michigan. She applies her health equity framework to her teaching and community organizing in the United States and in Jamaica. And I believe when Jaleesa signed in today, she's signing in from Kingston. So welcome, Jaleesa.
Thank you.
You can take it off now.
Awesome. Thank you. Can everyone hear me?
Yes.
Yes. Thank you, both Carl and Nora, for a very productive conversation about the changing landscape of drug user health and in the era of Trump administration, but also the politics of HIV prevention and organizing around drug user programs. And we'll just jump right on in to the panel discussion about drug user health. I have the Roundtable will share community efforts to address drug user health, and as well as consider policies that hinder the efforts and develop strategies to address that. First up, we have Charles King, who is one of the founders of the President CEO of Housing Works, Inc., a community-based nonprofit organization that provides a full range of services, including housing, healthcare, and job training for homeless men, women, and children living with HIV/AIDS and other chronic conditions. Charles is currently the co-chair of the Ending the Epidemic Subcommittee of the New York State AIDS Council, New York State AIDS Advisory Council. He also co-chairs the Act Now End AIDS Coalition and the Visioning Committee of the National AIDS Housing Coalition. And Charles holds both a law degree and a Master's of Divinity from Yale University and is an ordained Baptist minister. So welcome.
Thank you. It's good to be with you all today. I'm hoping everybody can hear me. I've been asked to talk for a little bit about where we are with supervised consumption here in New York State. We are working aggressively to become the first state that authorizes supervised consumption, and we have a few tweaks on it. I want to give you a little bit of background on how we got to this point, tell you how our program is unique, and also tell you where we are in the process and what things look like in terms of us being able to actually begin operation. So back in 2014, after some organizing that we were a part of, our governor, Andrew Cuomo, made an announcement on Gay Pride Sunday here in New York City, committing New York to ending HIV as an epidemic in New York State by 2020. Later that fall, a task force was convened, appointed by the health commissioner to develop a blueprint for achieving that goal. I was honored to be the community co-chair of that task force, and within 90 days we had come up with 37 recommendations by consensus that we put forward to the governor. The last 7 of our recommendations were what we called our Getting to Zero recommendations. They were the ones that we thought would be most challenging for the governor to accept, and included in those last 7 was supervised injection facilities or supervised consumption spaces. So that's got the issue put on the agenda. The governor accepted and endorsed all 37 recommendations, probably not thinking too closely exactly what he was doing, but he did it. And so one of my roles as both the head of the official working body with the AIDS Advisory Council, and also as the convener of the statewide community coalition, has been to work assiduously to see movement on all of these recommendations. And in fact, there are at this point only 2 of our 37 recommendations that haven't received significant movement. So we're quite proud of that. In 2016, coalition of syringe exchange providers came together in New York City, pressing for a way to advance supervised consumption, and were able to persuade the city council, the health committee being chaired at that time by our present city council speaker, to appropriate $1 million to do a feasibility study on supervised consumption that was assigned to the health, the city health department. Corey Johnson, by the way, is our present speaker and the chair of the health committee who led that through the city council. We saw another opportunity to take a bite at this particular apple. World AIDS Day a year and a half ago. The governor has looked each year since his announcement for something to say on World AIDS Day, and this time came to us with the request for an announcement that did not involve spending new money. We've tapped his pockets pretty deeply at this point, so we proposed that he announce a commitment to getting to zero HIV transmission through injection drug use and zero AIDS mortality. And I'm happy to answer questions about both of those. But our belief that we could get to zero is because in 2016, the last year for which we have data, we had less than 119 cases of transmission associated with injection drug use, down from 7,500. In any case, he made that commitment. That allowed us to form a work group basically around drug user health and how we would get to zero transmissions, and provided another opportunity to put supervised consumption on the table. Having put it on the table, we opened up conversation with the governor's office last June to try to move this idea forward. Interestingly enough, as we were beginning those conversations, one of the things that helped us significantly was that the AIDS Institute had issued a guidance to all supervised injection sites, warning about the possibility of overdose from people injecting in the bathrooms, and basically required each supervised injection site to set up a monitoring system to ensure that people who injected could do so in a safe and sanitary way, with controls in place to ensure that there were no overdose deaths. Several of the programs in New York have been a little bit more out there about how they've implemented this, including Washington Heights Corner Project, which has what they call the bathroom project. They have 4 bathrooms aligned together, and people literally bring their works and go into the bathroom. And all of us have set up systems at Housing Works. You have to sign out a bathroom key, and we set a timer for 3 minutes and knock on the door to make sure that you're okay. But this got in the news and created considerable controversy, and allowed us to move our state health commissioner from being in a position of being in total opposition to feeling like he had to do something, and therefore met with us and agreed that if the governor authorized him, he would sign off on a letter of authorization for a research pilot. And so we have been working on the assumption that we would put in place this research pilot this year. It took a little bit to get the city's report out, but one of our deliverables was approval of the mayor, police, and district attorneys in locations where the pilot sites would operate. And so we had to have Mayor de Blasio's endorsement. We finally got that in early May, with various restrictions placed on how this would operate. Unfortunately, that threw things in the governor's lap right in the middle of a re-election campaign. And so not wanting to go completely out there and draw attention, what the health commissioner has done in a last step, and there have been many, it's been a roller coaster ride, but the Saturday before Gay Pride, essentially in response to word that we planned to disrupt the governor's Gay Pride breakfast, the commissioner sent a letter to the mayor's office agreeing to set up a work group to finalize the guidelines for how these facilities will operate, and called for New York City to move forward with a community education project that the city mayor has made a requirement of this, with a quiet promise to us from the governor that we would receive the authorization the day after the November election. And so we're working towards that date and make it happen. There are obviously close to 200 supervised consumption sites operating around the world. We proposed ours as a research project for two reasons. One, we thought there were still new things to be learned, but second, the gloss of doing it as research was what brought people around to allowing us to move forward by putting our toe in the water. We've retained a principal investigator, Holly Hogan, who is a professor at NYU University, so we now have the support of NYU behind us. AMFAR is helping to coordinate and oversee the research, and what we've done is we've formed a 5-organization collaboration, have created a separately incorporated entity, Research for a Safer New York, that will be leasing space from the 5 organizations and operating a pilot. For 2 of those sites are in Manhattan, 1 in the Bronx, 1 in Brooklyn, and 1 in Ithaca, where the mayor came out in support of supervised consumption several years ago. There's 3 things that are unique about how our program will operate, different from elsewhere around the world. First, each of these supervised consumption sites is embedded within an existing syringe exchange program. People are already coming there to get their supplies, and indeed many of them are also already injecting in the bathroom. So this is what we see as an incremental step rather than something novel and new. The second thing that's innovative about this project is that we will be required to have machinery available that offers a complete chemical analysis of what people are injecting. People will just take a trace, put it in the machine. 15 minutes later, it spits out the analysis, which we will explain to the consumer. No one is required to test their drugs, but we are required to offer everyone the opportunity to test their drugs just so that they have an idea what they're putting in their body and the degree of potency. The third thing that is different about this is that it is our intention to co-locate with each one of these programs, limited primary care. We will be offering buprenorphine at every site. Within the next year, we think we will be able to offer also marijuana as a medically assisted treatment. But at the same time, we will be able to treat for HIV, prescribe PrEP for HIV prevention, test for Hep C, treat Hep C, STIs, all of those things right there on the site. We have engaged a law firm that has been providing pro bono counsel for us. They wrote an excellent memo on the inapplicability of the crack house is part of the federal drug enforcement scheme. And we have used that to great end, and they have also been working with us on some of the technical aspects, like actually getting insurance, which will be essential for us to be able to operate. It looks like we're very close to having a proposal for insurance. We went to a broker who operates in the marijuana space, so they're already familiar with insuring programs that run the potential of federal complications. We have now the endorsement of all but one of the district attorneys who we will be in, whose jurisdiction we will be operating, the Ithaca Police, the New York City Police, and are really gearing up with hopes that the first one of these 4 pilots will be able to open in January. I think I've used up the 15 minutes I was asked not to go over, so I'll stop there, and of course happy to answer any questions people may have after we hear from the others.
Great, thank you, Charles. And we'll take a few questions. If you have any questions, please feel free to raise your hand or type them in the chat box. And as we wait for questions, I have one question. So I thought what was really imaginative and innovative was that sort of diverse set of services that are provided on site, right? So the legal, the health, the treatment, and I also thought it was really interested in which the coalitional strategies that you have to employ, the community members have to employ as they're engaging with members of the state and also health departments and local communities as well. And so I think one thing I would want, I'll ask is if you can identify one of the, I guess the largest challenges that you've encountered in providing that services in service provision around in that diverse way that you outlined, and how you've overcome that.
Sure. So we've actually been on the forefront of some of the harm reduction innovation, and your question actually leads me to want to let people know a couple of other things. One is that we submitted under the Obama administration a state plan amendment that would allow us to bill for counseling services in syringe exchange settings. Actually, that was approved by CMS under the Trump administration last summer. And we have gone live with billing Medicaid beginning July 1st of this year. And so that has helped us overcome one barrier, which is how do you fund these activities in a climate where there are shrinking resources. The other thing that we have been able to accomplish overcoming some barriers is getting harm reduction recognized by our state Office of Alcohol and Substance Abuse as a legitimate treatment modality. Housing Works was the first OASIS licensed provider to have this modality approved, and there's now probably about a dozen providers around the state who are using this modality. So again, that has helped us to overcome some resources. More recently, it took a bit of a fight to get the state to agree to provide limited primary care licensure to syringe exchange programs. And we actually have piloted that and are waiting for our license to come through, but with a promise that based on this pilot, guidance will be issued this fall for all syringe exchange programs, explaining how they can go about obtaining limited primary care licensure. Beyond that, the barriers have all been political, and that has been somewhat exacerbated by the fact that in New York, we have a governor and a mayor who intensely dislike and mistrust each other. And overcoming the complexities of getting them to take 2 steps together has been our single biggest challenge.
Thank you.
I'd like to ask a question. I don't know how to raise my hand, so I'm just going to shout out. So Charles, thank you. It was excellent, very informative. And we're doing similar things in San Francisco, so I understand the process and how taxing it can be and how incremental steps, and but what the thing that has really, I think other jurisdictions are concerned, we could perhaps talk offline, but just this thing about the crack house laws and those statutes, because we find that we have existing organizations that would like to do this intervention, but there is this fear that the federal government could come after the assets of the agency for knowingly allowing drug use to happen. So I'm just curious if you could give us a brief why you feel like you have some confidence around your legal counsel on that. That'd be great.
Sure.
If you could share that.
Sure, happy to address that. And by the way, just a little bit of an advertisement at the harm reduction conference this fall. I believe it's in New Orleans. We will be convening a roundtable that will include a number of jurisdictions that are somewhere in the process of getting up and running: San Francisco, Seattle, Philadelphia, Boston, and New York State. We're the only jurisdiction where it's being advanced by the state with state authority, and that, I should say, does help provide us with comfort around the crack house statute. So essentially there are 2 issues. One is whether or not that federal law preempts states, remembering that we operate under a federalist system, whether states are preempted from regulating in this space. And there is no preemption language in the federal law. So the preference would generally be, and we seem to have an ever more conservative Supreme Court, so you would think states' rights would dominate. So the preference would seem to be that where there is no explicit prevention, state law prevails. And states have the authority for public health and police powers. And this comes under their police powers around public health. So we believe so long as it's sanctioned by the state, that we're not in violation of the federal law. That said, we have taken the precaution of setting up a separate corporate entity that will operate these facilities. So if the federal government wants to think that we are engaged in illegal activity, it is that entity that would be their target, as well as, frankly, we don't see how they could take criminal action against us without us joining the state insofar as we're carrying out a mandate issued by our health commissioner.
That's great. Thank you so much, Charles. That's very clever. Appreciate that.
Sure.
Are there any additional questions?
Yeah, I have one question. This is Nestor.
Mm-hmm.
Can you hear me?
Yes.
Okay, great. So I wanted to ask about any experiences around law enforcement engagement and participation, whether there is active engagement from the site specifically, and any adverse experiences with consumers.
So remembering that we're not actually operating the supervised consumption spaces yet, what I can tell you is that, interestingly enough, our Brooklyn district attorney has created a diversion program for people arrested under possession offenses. And that diversion program is actually less focused on getting people into treatment than it is focused on preventing overdoses. And so a person can avoid a criminal charge if they are arrested for possession if they will accept a referral to a drug treatment program, which can include a syringe exchange. And so we're having people coming in, and they have to sit in through at least one hour-long presentation on overdose prevention, which is done one-on-one. So we're actually receiving people who are coming to us because they want to get a criminal charge dropped. In terms of the operation of supervised consumption, we will begin meeting in August with the New York City Police Department and with the Ithaca Police Department, and are hoping that in the course of 3 months can hammer out exactly what our relationship is going to look like. They are very concerned. They do not want to see any increased crime in the neighborhood or other behavior that would have negative effects. We don't think that will happen, but that is their number one concern. We have concerns about if we had to call 911 for a reason, would they be coming on site, which would of course be scary for our customers. We also want to be able to report the composition of drugs in the aggregate to the state health department, but we don't want law enforcement to be able to use that information to track down and prosecute individual consumers or even their dealers, because that would, of course, make people stay away from the site. So we expect those conversations to open up. And frankly, since we now have the endorsement of both of the mayors involved, I think the conversation is going to be pretty productive.
Do we have any other questions? Well, I have a quick question before moving on to our next presenter. So we know that so you mentioned the diversion programs and drug treatment courts that come to mind as well. We know drug treatment courts give choice of, essentially jail or treatment as you described, or criminal charge or treatment. And it makes me think about this health equity approach that is becoming more important if we're trying to address drug user health in meaningful ways at the intersection of HIV as well. And one of the things I wanted to know is what are the community efforts and what have local organizations been doing to address like the equitable implementation of policies in this area, simply because we know that racially marginalized group and those who are socially economically excluded are the ones who kind of bear the disproportionate burden of criminalization as opposed to treatment, and this weird overlap in this way. So what has been the organizing and community efforts around this?
So I think there are three important initiatives underway that I can speak to beyond our work on supervised consumption and getting to zero transmission among people who use drugs. One is our drug user hubs effort. And so what we are beginning to see happen now is it started with a pilot, and now there are 13 of our 28 syringe exchange programs around the state are being funded with additional dollars that allow them to provide buprenorphine, Hep C testing, and those sort of things right on site. I think as we roll out the limited licensure primary care, that's really going to be a major step forward because we won't have to rely, again, on strictly grant money. We'll be able to receive insurance reimbursement for these activities. So I think that's been a real big interim step, but a major step forward. And by the way, we are pressing for, and hopefully we'll see regs later this year that will allow a different kind of low threshold syringe exchange. Any church, nonprofit, or local government entity can apply to get a syringe exchange waiver. They will be supplied with the syringes by the state. And this is to ensure that we have at least one syringe exchange point in every single county in the state, instead of the 28 that we presently have, which are largely centered in urban areas, with a few mobile ones in more rural areas. So that's one initiative. The second initiative is, I expect that it'll be announced in the next week or so, that, well, in March, our governor committed to eliminating hepatitis C, and what will be announced soon is the appointment of a task force on doing that. And of course, this gives us a wonderful advocacy platform, not just around hepatitis C and people who inject drugs, but being able to serve all of the healthcare needs of people who inject drugs as part of both identifying people, getting them cured, and keeping them from getting reinfected. And then I think the third big initiative that I hope will be announced within the next month is New York State is moving towards legalization of and regulation of marijuana, both a much more expansive medical marijuana rule and also legalization of recreational marijuana for adults. What we've been advocating for, and I think we've won, is getting a task force that will look at marijuana and at the same time look at harm reduction, both from the perspective of folk who have substance use disorder associated with their marijuana use, and the data indicates that somewhere between 6 and 10% of marijuana users experience it, their use as a disorder, but also being able to leverage the tax revenues from marijuana sales to address to pay for harm reduction strategies, addressing other types of addiction.
Thank you. That is highly informative and so encouraging. This, particularly the last part about leveraging tax dollars in that ways towards harm reduction. Thank you. And we'll move on to our next presentation by Paul Harkin. Paul Harkin is the HIV Services Program Manager at Glide Health Services and has been managing HIV prevention programs since 1997. He is a vocal proponent of harm reduction-based interventions and has initiated 2 syringe exchange programs in the Tenderloin area. Tenderloin AIDS Resource Center in 2000 and the current program at Glide, which started in 2011. As a member of San Francisco's HIV Prevention Planning Council, Paul continues to provide advocacy for underserved populations in San Francisco. Paul has an MA in Cultural Studies from East London University in England.
Hello there, can everybody hear me?
Yes.
Cool. So it's great to be on here today. Just want to say hi to my UCHAPS peeps and any guests that are here. I'm going to talk about integrated programming because, you know, we really have to learn from how these programs have evolved. We all began with like HIV testing, you know, HIV linkages to care. And we always knew that there was a bunch of other things happening there. One of the earliest things was we had syringe access programs, which used to be called syringe exchange programs. And when we talk about drug user health, it's shocking to me that we still have these siloed programs that perhaps all they do is HIV test and they don't have syringe access services on site. And I understand there's jurisdictional challenges for that. and certainly in any progressive jurisdictions, it doesn't make any sense to be referring people to syringes somewhere else. So the kind of programs that I've been involved in creating, and I want to speak as a person who is a community program manager and sees how it is on the ground and understands the challenges that our clients have when they are asked to go from one place to another, when things can be basically served up to them in a one-shop setting. So, what we have here is at Glide, we have a very integrated program where all the staff are cross-trained. It's very cost-effective because you've got HIV funding, I have Hep C funding, I have syringe access funding, but everybody can do the job of each other, so that when a client comes in for a syringe, that person who's serving them at the syringe site can also be their HIV tester, their hepatitis C tester, or their Hep C navigator, or their HIV navigator, linking up the care should they be have a reactive test. And we also have overdose prevention, and everybody's trained to do that. And it just makes so much sense if you think about, when you have something that drug users want, which is equipment for using drugs, whether that's crack smoking supplies, or whether that's syringe access, whether that's kits for snorting drugs or kits for smoking drugs. When you've got folks coming in for those supplies, you're already demonstrating that you care about them. They're demonstrating that they care about themselves, and you really want to, enhance that engagement by offering more and more services. So the more even if you as a program can't quite co-locate syringe access, you might have a syringe access program that's willing to have somebody there and do distribution and do Narcan training while you try and create that program yourself. You might have a syringe program and you don't have HIV or Hep C testing, but there's a program that's funded to do that. So you could partner with them and bring them in, so you co-locate services. I mean, the whole idea of drug user health is drug users know which programs serve them the best. It's very obvious to anybody who works with drug users which programs have cultural competency, which programs are able to engage authentically and demonstrate that they truly do care about drug users and treat them with dignity, with respect. They don't have any stigma, they don't shame, and they don't demand abstinence or enforce some other way of trying to coerce people into treatment, but literally meet them where they're at for reals. That's a crucial point, because many programs even will use the term harm reduction, but in fact they're not. So I think we really have to be true to what harm reduction is when we talk about drug user health. If your program isn't authentically engaging drug users in that way, it's going to be less successful than anyone that does. So, in San Francisco, we've been very lucky that we have a highly activist Department of Public Health that really wants to engage community partners. And, since very early on in the epidemic, after activists themselves started the syringe program, our Department of Health got in there a lot earlier than other jurisdictions and helped to legitimize it and help to fund it and help to make it more effective, essentially. But they always understood that the roots were the community-based programs, and our syringe program has always been based in CBOs. Jurisdictions where the syringe program is at the DPH, no disrespect to my DPH colleagues, they are less successful because DPH is seen as this official entity, and there's some negativity attached to that, and you just simply do not have the same connection with community that the CBOs have. And CBOs are better able to hire people who use drugs actively or formerly use drugs. They're able to engage peers in peer education programs, peer outreach programs, and just things that will generally always create a more welcoming atmosphere to the drug user. So if you're only doing HIV testing and you haven't even added hepatitis C testing yet, then that's a problem for your community, because we know that Hep C is killing more people than HIV. We know that many of the folks who are at risk for HIV are at risk for hepatitis C. And if you're looking at drug user health, then of course they are the highest. They bear the highest burden. People who inject drugs bear the highest burden of Hep C. And we also know that there's new treatments that take between 8 weeks and 12 weeks to cure people. So unlike HIV, where we have to maintain a client on medication for the rest of their life until there is a cure, we only have to get somebody through that 8 to 12 weeks for treatment. So it's unconscionable to have all that infrastructure set up for a HIV program and not already be including Hep C. And we would be happy at San Francisco to offer technical assistance to anybody who's in that dilemma where they're only having HIV prevention and they haven't integrated Hep C, because this is something that is low cost. It's something that your clients will respect you for. You'll build up better relations, and it's something that's very easy to implement. In San Francisco, it only takes 4 hours more training to do the rapid HCV test for a person who's already a HIV tester. So 4 hours of investment of staff time. And then, of course, you have to get the kits, and you might need confirmatory blood draws. But these are things that you already do for HIV, and your health department should support you in this endeavor, because the burden of HCV in this country is massive, and it's something that all HIV programs should be addressing. Now, when we talk about syringe access programs, either you have a syringe access program and you add in HIV testing, you add in Hep C testing, you obviously have overdose prevention, because overdoses are also killing more people than HIV did at the height of the epidemic. And it's very important that we are saving drug users' lives. Now, the great thing about the drug overdose prevention and education programs is naloxone is a very easy antidote to administer. It takes us about 8 minutes to educate a person on how to reverse an overdose. So there's nothing better than having the exact population at risk coming in through your doors every day and making themselves very easily accessed for you to additionally add naloxone training to the repertoire. In San Francisco, we had something like 1,277 overdoses reversed by drug users and their friends, as in not EMTs, not law enforcement, not paramedics, ambulance folks. So, when you engage the community, they do want to do their part, and super cost effective. And again, syringe programs, we have to get, I was so shocked to hear with this kind of funding that we lost a lot of Narcan that could have been distributed to community programs. And that is actually, given the volume of people who are dying in this country on a daily basis, that is a scandal. And I'm surprised that there wasn't more of an outcry over that outrage of allowing naloxone to, disappear. It could have been put in community hands. I mean, this stuff has an expiration date, so we have to move quickly and get it into the hands of community. Now, any program that's drug user health facing, the essentials are going to be adding Hep C and adding overdose prevention. How do you do that? If you have a viral hepatitis coordinator in your state, you work with that person. They're probably going to help you integrate the Hep C testing with your HIV testing. The populations that you're working with are the same. So again, I can't stress enough, it's disturbing that silos, the kind that exist, are still exist. Our thing is, we don't only wait for folks to come to our program for services. I believe, again, if you want to have a successful drug user health intervention, it has to include a very robust outreach component. And here at Glide, we have outreaches every day. We do particular outreaches that engage in picking up syringes and letting clients know about services. And then we have other outreaches where we bring out supplies for clients. So we're taking out syringe kits, we're taking out crack smoking kits, we're taking out condoms, and increasingly we're taking out kits for people who are, other drug users are still at high risk, whether they inject or not. So we've added snorting kits and smoking kits like foil and tutors. So, I mean, again, engaging drug users by giving them supplies that they want. And over time, we're building relationships, we build connection, because it really is about connections to the community. And we're drawing folks in for HIV testing, Hep C testing, linkages to HIV treatment or linkages to HIV care, whether they're previously known or get newly diagnosed by our testing program. Now, the other thing we do is we take our testing into the community. A lot of programs, the folks will sit in their office and just, and they do a good job of testing people who present for testing. But again, if you want to talk about drug users who have competing needs and interests and, sometimes living in chaotic situations, convenience is an enormous factor in how we engage those folks. So by us going out and doing this outreach, we build up relationships, and then we'll do community street events where we'll set up our tent at locations where there are basically encampments with a lot of homeless folks who are drug users. And we'll set up our tests there. We're doing HIV, Hep C, and we're doing linkages. But we also partner with a group from the Department of Public Health called Street Medicine, and they'll be doing initiation onto PrEP. They do Suboxone. They'll do STI testing, and they'll do pregnancy testing for folks. So we bring this total integrated model out onto the street, working out of tents, and it's highly successful. There has been some challenges with re-upping people on Suboxone because they are homeless folks who tend to be living in camps, and there's, like in a lot of cities, we see a lot of harassment of homeless folks, criminalization of homeless folks, and it makes it harder to track them because these camps get what San Francisco calls resolved, as in they disband these camps and move these folks in a very harassing way. So it creates challenges for follow-up. But, it's again, in the next phase of this harm reduction with drug users is getting outside the clinic walls. I mean, we heard some great things from Charles King, the integrated program services that are going to be offered at these safe consumption spaces. San Francisco, likewise, is very close to opening these venues. And we also chose to have them in spaces that already have drug user cultural competency, drug user rapport, drug user services. So we want to co-locate them. It's just another service on the continuum of healthcare for drug users. And, it will reduce the likelihood of NIMBYs protesting at a venue as it starts to provide these services, because drug users come to our program every day, and drug users come to the programs that are also being considered for the implementation of safe consumption spaces in San Francisco. And the point being is that we have that cultural competency, we have that cultural capital with drug users. We are the place where it's most logical to locate it. So, I think the next phase is not only we'll have buprenorphine access there, we'll have STI testing, the fully integrated programming, because this is a great chance, a great opportunity to work with chaotic drug users just simply by reducing that chaos of public injection. And I'm sure it's similar in other jurisdictions where some of the support for this isn't actually coming from people who I would describe as being the most compassionate folks about people who are injecting drugs in public spaces. They really are folks who find it repulsive that drug users are injecting in public spaces, and they just want them removed. However, we can see here that these folks, for whatever reason, they can become supporters of an intervention, even though they're not coming from the same space. And of course, nobody likes to see public injection, least of all those folks who are injecting in public, because I work with them on a daily basis. I've done surveys with them. People do not want to be in that situation. But we also have a homeless crisis in San Francisco, and so that includes a lot of homeless active drug users who have nowhere else to inject. And similar to other jurisdictions, public bathrooms, bathrooms in programs, and we've all initiated protocols to try and ensure that folks do not die in our bathrooms by having timers and naloxone trained folks present, and we constantly monitor our bathrooms. But given that that's already happening on a grand scale, it makes no sense that we haven't already just improved upon that intervention and created safe consumption spaces. So I just wanted to check my time here before we go to questions. How am I doing on time, Jalicia? Am I okay for time? Should I keep going?
Oh, are we okay with time?
I didn't set a clock.
Okay. So we're good with time? Okay, awesome.
Okay.
Yes, please continue.
Yeah, so I just want to summarize again. What I'm saying today is really, as program managers, as health departments that can support community-based programs, we have to break down the silos and really forcefully advocate that programs become much more integrated. At the very least, you're talking about HIV and Hep C testing, linkages to care being co-located. It's no-brainer, it's super simple, it's very cost-effective. We also want to add syringe access to those programs. It doesn't, like what you heard Charles saying, we don't want people having to drive all the way across cities to get sterile supplies. It makes no sense for the cost effectiveness of syringe access. It is the most efficacious public health intervention we've ever had. It's even more efficacious than vaccine programs. We have reduced HIV, the burden of HIV in people who inject drugs, where we have syringe access, to very, very, very small amounts of folks. And a lot of the reasons that even injectors still get HIV is there isn't sufficient access to sterile equipment. So that's something that we can easily do. I know that some jurisdictions have major challenges with that. And I would just like to say to those jurisdictions that if you get in touch with the Harm Reduction Coalition, there is usually underground syringe programs, and there's ways of partnering with them to try and ensure that all injectors get the right to have access to sterile equipment. All injectors, when given that opportunity, they want to use sterile equipment. People do not want to contract HIV or Hep C, but because of their substance use disorder and lack of access, then they will take risks. And that's unacceptable that we haven't addressed that. And the whole syringe ban was a disaster. And I think one of the reasons that we have so few folks that get HIV from injecting in cities like New York and San Francisco is that they were super early adopters of syringe programs. And we also, therefore, had this complete network for our drug overdose and prevention education program that, San Francisco's never had more than 220 deaths a year from overdose, including now during this crisis and this uptick in fentanyl poisoning. So, it says a lot that a lot of people have missed the opportunity to already be building up that network. And rather than dwell on the past, we need to look to the future and start having these programs, because this opioid epidemic is not going away. And we need to get boots on the ground, programs on the ground in all these jurisdictions as quickly as possible. And so, that's my message is stop thinking in silos, start integrating, and, have a focus on drug users. Because when we talk about getting to zero, we have to include drug users in that vision. And a lot of programs have very much targeted sex with men. And a lot of men who have sex with men are obviously injection drug users as well. And the cultural competency can start to fall off as it gets into substance use disorders. And we need programs to recognize that. And we need to recognize the racial disparities and have programs that are culturally competent across race, across ethnicity, and across substance use disorders. So that's my presentation for today, and I'd love to take any questions from anybody who's remotely interested. Thank you.
Thank you so much. Thank you, Paul. We're actually going to jump on into the next panelist before taking the additional questions, and hopefully at the end we can gather all the questions and give you time to follow up on any additional information you wanted to share.
Okay, thank you so much.
No problem. So today, our final panelist, last but not least, is Patrick Chalk, and just bringing up the bio. And Patrick Chalk is the Assistant Commissioner of the Bureau of HIV STD Services at the Baltimore City Health Department. Dr. Chalk is the co-chair of the Baltimore City HIV/AIDS Commission and HIV Planning Group. He also is a member of the Greater Baltimore HIV Health Services Planning Council. Dr. Chalk is a pediatrician and preventive medicine physician with extensive experience in infectious diseases, including STDs, tuberculosis, and HIV. Your line is open.
Can you hear me?
Yes.
Yes. So after hearing those two wonderful presentations, you can dump my slide set. I'm going to talk from practice here and talk a little bit about how our program is changing. I think the integration theme that Paul raised is a really important one that we've been trying to follow. By history, we started syringe exchange as just syringe exchange and HIV testing in 1994, because at that time, about 64% of the new HIV infections were related to injection drug use. And it was about 773 people. And in 2016, it was down to 29. And I've seen some preliminary 2017 data that suggests it's going to be even lower. So as both speakers indicated, this is a very proven approach that public health has really shown to be very effective. Our challenge here in Baltimore is twofold. One is we don't really get the resources we need to do a lot of the stuff that we'd like to do. So we are funded by city general funds and some state general funds. And the other issue for us is medical mistrust, which is deeply rooted in the city of Baltimore. And so when you're trying to do anything that's health or public health, you really have to confront that at the very beginning, which means you need to be creating welcoming environments for people. You need to be connected to the community, and you need to be transparent. And so over the time, we have moved from just 2 sites with 1 mobile clinic to now 15 sites with 3 mobile clinics. So we take the services that we provide out to the community. And I think as Paul was indicating too, that's something that you really have to do. We've sort of learned in Baltimore that people really don't want to go more than about 5 or 6 blocks from where they live, particularly the people that are marginalized. So we thought it was better to actually take services out to the community, and we've been doing that since 1994. We pick the neighborhoods in conjunction with the neighborhood associations, and in most cases, they'll approach us and say they've discovered this new problem of syringe use in their communities, and they'd like us to help. And that's kind of how it starts out. So we usually spend a fair amount of time with the community association. Our latest site is our first fixed site. It's in one of the sort of the older neighborhoods of the city, and we've worked with the church to open services there. They approached us. We spent surprisingly about 8 months trying to get this organized and accepted widely in the community. So some people back here were surprised when they found that it took us that long to actually get this done. The church is great. The pastor is very, very innovative. We use the basement of the church for our services, so people don't have to wait out in line. The minister provides food and coffee for clients when they come by. He's got a food bank, a clothing bank, and he's going to install 2 showers in the basement for homeless people. The response we've gotten from the community, and particularly the business community, has been very, very positive. They were concerned about all those syringes that were laying around in alleys and other places. And with our teams going out to collect those and having clients getting sterile syringes at the church, it's actually improved things quite a bit. I would say that some of the strengths of our program are that my staff actually are from the community. We make sure that we have people who understand addiction, and our staff are pretty much that way. And so they've created really solid relationships with our clients. We're a little different in the fact that ours is a confidential exchange system. So in other words, we take names and addresses and personal information. That wasn't how it started out, but in about 2004, I think, they went to name-based confidential. What that's allowed us to do is actually create even stronger relationships with people. By the time that we went to confidential, we had already been around for about 10 years. And so I think there was a lot of trust from the clients with our staff. But it also allowed us a couple years ago to actually give the list of HIV-infected syringe clients to our data people who did searches in CareWare and other places and identified about 40% of these people were out of HIV care. So we then reached out to them with our care linkage team and got those people locked back into care. And we're probably going to repeat an analysis of that again, maybe in about a year. We have had 2 changes in particular that have made a big difference for Baltimore. About 2 years ago, after the 3rd year of trying, we were able to get the syringe exchange limit from 1 for 1 to what we call a needs-based. So we can give out more syringes than people bring in. And that's kind of important because obviously people can't come back to the site where you're at every time on a predicted basis. We're also the only jurisdiction in the state that's allowed to have a syringe program. That was changed just this last year. So we're starting to see some uptake in some of the other counties around the state, but it's going pretty slow, and I'm not surprised at that because I think the enthusiasm for the opportunity to set up additional sites kind of overlooked the planning that you need to do to put those programs in place. You need buy-in from the police, buy-in from the treatment community, buy-in from the business community, buy-in from the community association. So I think that takes some time. And we've been providing technical assistance to some of the counties with presentations. We bring them into Baltimore. They do ride-alongs with us on our van to see how we do our work. I think most of the other sites are going to be using fixed sites. Other counties are going to be using fixed sites. We've just found that the mobile approach seems to be really effective. And if we find that we're not having a lot of uptake in one of those places, then we can change to another site. So right now, with the new law in place, we can also now partner with CVOs to do syringe exchange in Baltimore City. And we've been talking with a number of them about how to go forward with that. We've expanded over the last few years a lot of the service, the integrations that Paul was talking about. So we do obviously Hep C and HIV testing, but we also do referrals for drug treatment. And the latest thing we're adding to that service is that we're going to get peer recovery specialists to be out on the van with us, so that when people come in and are ready to get into care, we don't have to waste time trying to find a place to send them to. This person will take them into care right away. And I'm really looking to hope that that really takes off. I don't know how many times I've been out there and someone will come up and say, you know, I just can't do this anymore. Can you help me? And you get on the phone, and then they finally just say, well, I'll just come back some other time. So I don't know if that's anything that your program does, Paul, but we're really looking to the peer recovery folks to be a real big asset to us. We do naloxone training like you do. We had a program called Staying Alive that was founded in 2004, and that was geared to trying to get all of our clients trained in the management of overdose and giving them kits of naloxone. Last year, I think we had about 950 clients report providing overdose treatment to a friend of theirs. So as you were indicating, Paul, that's where the training needs to happen, is with people who are out on the streets with them. And we usually always advise them never to use alone, always use with a friend and have naloxone handy. We're looking at safe injection here in Baltimore. It got pocket vetoed in the legislature last year, but I think it might get raised again possibly after this next election, because we got the elections coming up and it won't be a very popular approach. And we'd be really interested to see from Charles how your New York work goes with that. I'd really like to follow up with you on that. I think it sounds like you're doing some really fantastic political and legal work around harm reduction. I would also say that some of the services that we provide include not just the testing stuff, but we've provided wound care in the past. We had an infectious disease wound care specialist from Bayview Hospital who donated her time out on the van to 2 or 3 of the sites a couple times a week. She unfortunately left about 2 years ago to North Carolina, and we are just now starting to resurrect that program. We've got a new van called the Spot Van, which is Get Healthcare on the Spot, which is ultimately designed to bring all the services that we provide in our 2 health centers out into the community in this van. So we will continue to do reproductive health, which we do on the van at one site, which is down in the Exotic Dancer Block downtown in Baltimore, and provide a lot of female services to them, Pap test, pregnancy testing, and birth control. We have substance use treatment with our new peer recovery folks coming on, which is going to be really important for us. And we do vaccines in the wintertime, particularly flu. We do overdose prevention outside of our clients. So we tend to go to big events like our Artscape, which is 750,000 people that'll be coming up in this next week. We bring our services out there and provide training and naloxone kits, education. We do some enrollment for insurance. We work with a group called Healthcare Access Maryland, which is a nonprofit that works on expanding healthcare coverage for uninsured and poor folks in the state. And so they tend to be out at a couple of our sites each week to help get people insurance if they're able to get that. We've got a couple of campaigns that we've started over the last 2 or 3 years with our new health commissioner. The first one is Saving Lives with Naloxone. That's the work that we do with our clients, but also we go around to these different events that I described and provide training and naloxone access. We do a big public education program called Don't Die, which is sort of, as marketers would say, above the line social marketing, so that it's ads and television and radio and stuff like that. And then access to treatment 2-3 years ago. We began, sorry to say that it took us so long to get that far, a 24/7 hotline for peer recovery. And that's manned 24 hours a day, 7 days a week. They had a line before that, but of course it was like 7 to 5 or something, which was absolutely embarrassing to think that we thought that was being responsive to the community. So I would say that some themes I've heard here today that I would like to reinforce is, one is the client relationship that we need to create. And that relationship can be created if we are more responsive to their actual needs other than just HIV testing, as Paul was indicating. And I think creating environments that are really welcoming for these folks, you know, we sort of see them as we are the only link they probably have with the healthcare system at all, unless it's going to the emergency department. And we've heard pretty gruesome stories about that experience by them. So I think we are working in that sort of contemplative stage of change. And if we can get that spot right in between that, where they're just about thinking about wanting to get help, we will be there to help them do that. And I think that's part of our obligation to do this. And I think, as both speakers said, this is sort of an evidence-based public health model run by public health people who are treating just the right people with interventions that they really need. So I'm happy to take any questions. I'm sorry to depart from my slides, but I don't think those were in line with the conversations that we're having here. So if there's any other thing I can answer, please go ahead.
Thank you. So if you have any questions, just raise your hand or type them in the chat box. I'll just briefly state a question to give you all time to respond. But thank you all for this very informative presentations and discussions. And several things stand out, but I'll limit mine to create space for the other participants. One of them is basically the importance of this synergy across different actors, right? So the public health departments, community organizations, governments, the people on the ground, and using this synergy to really create culturally informed services. And that was something that came up often. And I guess I'm just interested to know how we can both interweave these culturally informed approaches with the sort of racial equity work that I've heard in different regard yesterday's conversation and today's conversation, to really address some of the, the ways in which good intentioned efforts really contribute to the marginalization of the people who are supposed to be the targets of a lot of these interventions. So if we're thinking about these shared visions, these shared objectives, how do we sort of address the counterproductive ways that we implement, imagine, and really, implement and imagine programs, not in that order, but imagine and implement programs for this population. So how can we, interweave, I guess, this sort of racial equity approach and this cultural competency that I see being weaved out in different ways to address the multiple facets of the issues that we all engaged with. If that's something you all thought about, if it's something that is not on the agenda but is in conversation, how do we think about that in a way that's more integrated, strategic, and sustainable? And then I will open it up to the audience. Hello?
Hey there. I would like to say something around that. Yeah, I think our program, we work in the Tenderloin neighborhood, which is racially diverse. And we track our data, and data does inform programs if it's collected properly. And we notice things like the majority of people who come in for services were Caucasian. The majority of folks who were receiving services on the streets were African American. And it was like, what's up with the space? Is it privilege? Is it white people feeling more entitled to walk in and ask for their needs versus African Americans in San Francisco face a lot of disparities, particularly for drug users with law enforcement and highly selective prosecutions. We also have a law-assisted diversion program. And so we're trying to look at this whole picture of, the sort of hierarchy of needs that people have, the holistic view of the person, dealing with folks' trauma. So our programs are informed and intentional in the way that, so for instance, that's when we found a lot of young African American folks were smoking fentanyl from foil. So they weren't coming into our syringe program. We have a 40 hours a week syringe program. But they weren't coming in. But even though we go out in the street and we give out smoking supplies, we started to learn from folks that they were smoking fentanyl. So we brought out test strips for people so that they could test, people who weren't intentionally using fentanyl were also like smoking crack or crystal meth, and we were finding some of that was tainted with fentanyl. So it's like, the delivery system of the programs is informed by the client needs. And so a lot of the things that we were doing when people came in-house, we just started doing in the street, just like we do the overdose prevention right on the corner. We're sitting there and we're training up people on how to use the fentanyl strips and how to do a naloxone reversal. And we're doing all the paperwork and, bringing it all to the street. So I think, programs, that's a crucial part, is that willingness to meet clients where they're at literally, and to incorporate different sort of cultural comfortability with programs that are set in buildings. So that was just an example of, something that evolved in our programming, and we continuously review, across our data, what services, who we're touching here, who we're touching there, why is this for this population but not those, and we're constantly trying to evolve to meet client needs and address whatever it is that might be some kind of barrier that we're even unaware of, because nobody's going to just be perfect for every population, and we hire from all the different communities to make sure that people see people like them delivering these services, and that's a very intentional thing too.
I'd agree with Paul 100%. I think that we put a real premium on being out in the community and getting to be recognized. Even the drug dealers don't bother us because they know that we're helping their clients. We've never had any issues in the community ever. And I don't know how many times I'll be on the van and we usually get a big thank you from the client for saying that we're really responding to their needs. So I think it's a little easy to overlook that. But again, our staff are professional in the sense that they're from those communities and they know the communities and the communities know them. And so that does a lot to help our work and keep people coming back to the van. We've actually experienced that with our HIV work in the last 4 or 5 years. We've been doing a lot of videotaping of storytelling events in the LGBTQ community. And that has allowed people to express their voices and who they are, and people that have always been marginalized or not had a chance to talk about their lives. And so by creating those, that's really created an opening for us to work where we would never work before in the LGBT community. So I think that we're learning as a health department the real value of listening and being transparent and trying to be responsive to all their needs that we can. So I totally agree, Paul.
Do we have any other questions?
Okay, for those who are calling into the line.
I have a question. Hello?
Yes, hello?
Okay, can you hear me?
Yes, I can hear you.
Okay, thank you. This is Crystal from Houston. So we talked about some policy and some direct work that's being done. What would you say to organizations that are in the South that they may already be providing testing services for HIV and Hep C, but are challenged with the policy issues? What feedback or guidance would you give to organizations to kind of advance the work around harm reduction or safe drug use? And I'm particularly talking about the organizations that are in the southern region of the U.S.
Right. So the Glide Foundation is co-located with the church. If there's a way of lobbying any of these faith-based organizations, you'll find some of the churches will support syringe access. Certainly, most folks are going to support overdose prevention. So sometimes it has to be done by incremental steps. I mean, I think you'll get broad agreement that people should not die because dead people cannot do recovery. And so you asking for naloxone and getting naloxone into the hands of drug users in the communities, utilizing peer-based programs, maybe incentivizing peers that can get out there and link the service to drug users is a way that that works in any jurisdiction. If there's a lot of money for naloxone nationally. Different states have different ways of getting it. So I don't know what the deal is for the South, but you can certainly use this leverage that the opioid crisis and the sheer volume of people who are losing their lives to overdose as a way to try and get a wedge in there to allow naloxone distribution. And that's beginning to start to recognize that folks are, using drugs and need life-saving services. And then once you start agreeing to reduce overdose deaths and provide naloxone, it makes sense to then ask for sterile equipment for people who are already injecting so they don't get HIV or Hep C. There's cost-effective arguments, there's moral arguments, but it's really about coalition building. Perhaps if these folks have HIV community councils, whether they're care councils, whether they're prevention councils, or if they're joint and merge councils, the jurisdictional plan. These are entryways to look at this population that in the South is probably extremely marginalized. I mean, I myself did a syringe program underground in Key West, Florida for 3 years. And I also did HIV and Hep C testing in that program. And personally, I tested more people than the whole health department because of the stigma of being seen through my underground techniques of testing people in the back of my Oldsmobile 88. I was able to test hella people. Now, so one person can make significant inroads, and it's finding those champions that are prepared to go up against, the law. I did it very smartly and told the cops that this is what I was doing because I believed there was a health necessity and was able to get law enforcement to buy in. And it's looking for those kind of strategic alliances and get something grassroots going, and then you try and build upon it. It's not easy, especially when there's a very conservative backlash against drug use, but you'll find that every pocket there's folks that are compassionate and people who are 1 degree of separation or 2 degrees from drug users, or their own personal history, right? And so they are more sympathetic to keeping drug users alive, getting drug users treatment, for HIV and for Hep C. And it's a coalition building of like one brick at a time, but it's all definitely doable.
Thank you.
I have one question from the chat box. All right. We have a question for Charles King about the federal policy. You referenced the crackhead policy. Can you just let us know more about that again? All right, Charles, your line is unmuted.
Well, I can tell you it's actually the crack house policy, not the crackhead policy. But yeah, so
apologies.
It's basically a law that was enacted during the height of the crack, I'll call it the crack hysteria period in American history, where, you know, it was the notion of crack was used to increasingly racialize drug laws and to disrupt communities, to create armed enforcement of that we had never seen before, to go into communities of color particularly and target them. And so because there was derelict and abandoned buildings that were being used, but the landlord still owned them, they created a crack house statute that was to prevent people allowing their buildings to be knowingly used for drug use. So even though a safe injection facility or a safe consumption space doesn't really fit what that was intended for, as it stands, there's legal scholars still believe that law of knowingly allowing drug use to happen could be used, and therefore there would be asset forfeiture, which would be they could take the building, and your building might, like Glide's building, houses many, many other programs. So people want to be legally indemnified from that risk. So that's why the crack house statutes are often, it's a colloquial term, they've obviously got a more proper name than that, but that's what they're colloquially known as. And it's a barrier for anybody who's looking to do safe consumption at this stage until precedent is set.
All right, for those who are calling in, we are going to open the lines, but if you don't have a question or you're not ready to speak, please make sure that your line is muted. We're going to open all of the lines. Yes. All right, the lines are open. If you have a question,
everything went well. She got up. Everything went as expected. You saw that you know, when was the last time she was up? Last Thursday.
Hello.
Yeah, I mean, when we got in there, I wasn't sure like how long it's been. It's hard to really tell.
How are you?
It's good. Schools like one of them, they really do epidural, so she really didn't get much anesthesia. She's in the program, very comfortable. All went well. So they'll get her moving.
I stayed at a hotel.
She's in recovery now. Yeah, she's comfortable.
Since there are no questions at the moment, I'll pass the mic back to you.
I have other questions for you. As far as medical,
I recommend you ask people to mute their phones or go ahead and mute everybody.
Mute everybody.
Okay. So there was a needle stick that occurred in one of these systems. I got my recovery. To look at some of her eyes. That's just to confirm.
Got a new phone and I can't access it.
It's not going to require another blood.
Okay, so this is Jeffrey chiming back in. Jalecia, did you have anything, any words to wrap up that particular roundtable discussion?
All right, so hearing no questions and seeing no hands raised, are there any final comments from the panelists or from the moderator? Jeffrey, if you have anything, feel free.
Yes, can you hear me? Hello?
We can hear you.
Okay, great. Perfect. Thank you, Paul. So yeah, just to finalize, I want to just take this opportunity on behalf of UCHAPS and certainly our steering committee to thank all of you who were roundtable discussion members or panel members, and also to Carl and Nora for your contributions to our conversation today. Is absolutely an amazing conversation. I said this yesterday, I'll say it again today, that the diverse elements that UCHAPS brings to the table regarding our HIV epidemic and the different things that impact it certainly always keep me in awe. So this conversation about drug user health has certainly been beneficial to me. So as we're about to close out, I want to encourage all of you who are on the call today to take about 30 additional seconds before we close out and you go offline to complete today's survey, our survey via SurveyMonkey. So if you would do that before you sign off, we would appreciate it. That information is going to be reviewed, and we will look at how we can improve the work that we're doing, not just on these types of calls and on the, I think the soon to return face-to-face meetings, but the work that UCHAPS does overall. So we really appreciate your time today. Thank you so much. Thank you again to our facilitators and our discussion panel members. A big shout out to our panel members who are also membership at UCHAPS. That's Paul Harkin and Patrick Chalk. Thank you very much. And I'll send you now to complete your survey, Monkey, and we'll talk later. Thanks.
And I just remind folks that UCHAPS does do technical assistance. If there are any folks that are interested in that, to contact UCHAPS, as we know that sometimes that's what helps get people over that hump. And that's one of our tasks in this world, is to help people with technical assistance. Thanks.
Thank you, Paul.
Right, and absolutely, if you would like to request technical assistance, you can go to our website at uchaps.org, and at the end of the page, there's a link there to request technical assistance, or feel free to reach out to us at info@uchaps.org.